Thank you for coming and joining us this morning to get a glimpse of few of the important factors that is going to change the way we are going to practice echocardiography as we go forward. A quick show of hands, who are all from outside Karnataka and Andhra? Could you please raise your hands? Wonderful. That's good. Okay. So my topic today is the introduction of myocardial mechanics, strain and strain rate. And when somebody tells me, hey, strain rate are so advanced, no, let me stick to something basic, I tell them no. Okay. Understanding strain and strain rate is one of the most important aspects that you and I, as people who will treat heart disease, who will diagnose heart disease, we need to know. We need to know this because this is going to be the future. And it is important for us to understand how the heart functions, and only then will we be able to guide, treat, and make people better. So here are some of the few problems that I face, and I have to be honest, in my routine clinical practice. And there are times where I know the symptoms of the patient and my echocardiographic findings don't quite match. And I'm sure all of you would have faced the same thing. The reason is that the tools that we use, though they are good, they don't give us a complete picture. When I say tools that all of us are used to in day-to-day practice. A second problem that I face is that there are times where I'm not able to pick out or I have doubts about hypokinesia. Okay. And I have to be honest, sometimes I even look at an ECG, though it's kind of cheating to know, but at times you are not able to pick out regional function that well on the present tools that we have. These problems are overcome by the use of new tools such as strain and strain rate. And as I said, that this is going to be the future, and don't let anybody tell you that you can't do it. One, don't let anybody tell you that no, this is too hard for me. It isn't. And I hope over the next half an hour that I will be able to demonstrate to you that yes, this is something that I can do. Starting first with what is strain and what is deformation. As the heart contracts, it changes in length, and any change in length is the deformation. As the heart contracts in systole, the myocardial length decreases, so it becomes shorter, and that is the deformation. So if I can measure how much a segment has contracted, that is the simplest definition of strain. So here is the initial length that you have, and here is the length at the end of an event. And if I can ratio between the initial length to the change of length to the initial length will give us strain. This is the simplest. And let me give an example. Say if you have a segment of 10 centimeters and the segment now becomes 8 centimeters, you have a negative deformation, a negative strain of minus 20. So it has shrunk by 20% or it has contracted by 20%. And strain, because it has both lengths on both numerator and denominator, it does not have units. We can express it conveniently as a fraction or even as a percentage like all of us do. So a negative strain means a segment has become shorter than its original length. Now if it was 10 centimeters and it becomes 12 centimeters, that means it has elongated, and it is elongated by 2, which is 20%. So this segment has a strain of plus 20%. And if it is remained the same, then it is 0% strain. So strain is something that you and I can understand very clearly. It is expressed as a positive if there's elongation, or if there's contraction, it is negative. And the unit that we use is a percentage. Now, knowing strain is not sufficient, and I'll give you two examples. Say you have two segments and both are 10 centimeters, and at time 0 they're 10, that is at rest. At 1 centimeter, okay, your one in blue, is elongating more than the one in the red, and 2 centimeters, the one in blue is already 20 centimeters compared to the initial 10. So you have a plus 100 strain on that, versus it took 4 seconds for the red one to elongate to the same 20 centimeters. So both these segments have exactly the same strain. They've elongated exactly at the same length. However, the top one took 2 seconds versus the bottom one took 4 seconds. So it is important for us to know how long it took for this deformation to occur, and that is called the strain rate. It is quite simple as that. It is in unit time, so it took 2 seconds for the top, for the blue, so strain rate is 0.5 per second, and it took 4 seconds, so it's 0.25 in the red. Another quick example, Chris Gale and Dravid may have scored 50 runs each in the same over. However, Chris Gale would have done it in 20 balls, versus Rahul Dravid would have done it in 110 balls. They may have the same strain, but their strain rate is entirely different. So please remember that you need to know both the strain as well as the strain rate to understand and to quantify something accurately. Point number 3, which is the basics that I would like to tell you, is what is tethering. The tethering motion is exactly like my son's toy train. Okay. The motion is there at the engine, and all of these follow through exactly at the speed at which the engine is pulling. These carts don't have their own power. They're just being pulled by the engine. And this is another characteristic of the myocardium. Okay. You could have 2 segments. Okay. And if I were to assume that the black one is dysfunctional, or it is not contracting, and it is being pulled by the red segment. Okay. Translational movement is what we call tethering, as in it will pull all the segments along with it, and the black one will also move. But it doesn't mean the black is contracting. The black segment is just being pulled or tethered by another segment. So when we see in our 2D movement, it is difficult sometimes for us to know whether the movement is due to the contraction of that particular segment, or is it being pulled along with the surrounding segment. So that is a very important point that I would like you to remember, that myocardial tethering is something that we need to keep track of. In deformation, or what happens is, as it is being pulled, it also contracts. So if we can measure the amount of strain or strain rate those segments are undergoing, we can know which is the one that is actually being pulled and not contracting, and which is the segment that is actually contracting or actually doing the pulling. So another important concept is of myocardial tethering. So we have 3 different, therefore, but for the sake of simplicity, there are 3 different aspects of strain and strain rate imaging. One is simple velocity, that is, we know how fast or slow a myocardial segment is moving. Okay. If we have the distance along, another measure, we have the strain rate. And if you have time as well, another piece of information, we have strain. So it is like how the shortening velocity of a particular segment is, how fast is that particular segment contracting. Okay. And what is the shortening rate in which it is contracting if we have a component of time which is called strain rate. And the total amount of shortening that has occurred is called the shortening fraction, which is the strain. So these are 3 terms that can be derived one from each other if we know the distance and if we know the time and the velocity. Okay. So you have shortening velocity, which is the myocardial velocity, shortening rate, the rate at which it is contracting, which is called the strain rate. It is measured per second. And I told you the shortening fraction, or just strain, which is measured as either a simple fraction without unit or expressed as a percentage. So these are the 3 terms that we will use to describe strain and strain rate imaging, and most important, myocardial mechanics. Why is strain and strain rate important to me? Because this is not about intervention. It is not about anything else. It is about your ability to understand how the heart is working. It is nothing more than an extension to applied anatomy and physiology. And that's all I want to talk about. My two favorite topics, physiology and anatomy. And if I am able to tell you a few things about anatomy and physiology and their correlation within the myocardium, I would have been successful in letting you know what myocardial mechanics are. And I and you will be good myocardial mechanics to understand how the heart is working and then help our patients. Our heart is not just a single band of tissue. That is one very important thing. Our heart's muscle fibers are oriented differently at different locations, and it is done so in a beautifully designed way as a helix. There are two helixes of myocardial bands within our healthy heart. So within the endocardium, as we dissect the endocardium, you will find that the myocardial bands run obliquely in a right-handed helix, versus in the epicardial region over here, it is a left-handed helix. So God's creation of the heart as two opposite helical structures is what contributes to the heart's function and our ability to do what we do. The helix, of course, wrap around at the apex where they go to and this has been known not now, but from the time of the 16th century, where the earliest dissection of the heart, they were able to identify the two different types of fibers that run in a crisscross fashion. So they not only improve the function of the heart, they also add more strength of the heart. Nowadays we have tagged MRI and MRI fiber studies where, thanks to neurologists who are able to map how they map the individual neural pathways, the same technology can be applied for the heart muscle. And here you can see the subendocardial helix of the right hand and the epicardial left-handed helix. Why is this so? The heart actually contracts if you actually take 15%. That's how much, 15 to 20%, the heart actually contracts. Okay. It doesn't contract 60%, it contracts 15%. So how do we get an ejection fraction of 60% from a contraction of just 15 to 20%? That is because of these double shape of these helix, and that's how the heart is so beautifully structured that it allows the heart to work at such beautiful efficiency to get an ejection fraction of 60%. Now, the motion of the heart, and this is point number 4, is not just in one direction. Okay. And this is important also to know that the heart's motion occurs in 3 different planes, and each plane orthogonal to each other. The first, or the longitudinal contraction, is what we see in our echo. Okay, as in a 4-chamber view, we see the heart contracting and relaxing, and that's what we are so used to, and that's what we appreciate. Ejection fraction, for instance, just measures this. It just measures one of these motions, and that is the longitudinal motion of the heart. However, the heart moves in 2 different sorts of ways, which is not measured by our tools, and the others are circumferential, that is, there is rotation of the heart, and radial, the heart becomes thicker. Now, radial motion we know that when the heart contracts, it will thicken, and when it relaxes, it thins out. So this is the radial motion of the heart, where it becomes thicker and thinner. The torsion, or the rotational motion of the heart, this we are able to see from the apex at very high frame rates. And surprisingly, I am always surprised at the beauty of our heart, is the fact that this twisting of the heart, say if I was to ask, how would you if I was to give you a cloth and full of water, how do I dry it out? I would twist it. Okay. That is the most efficient way of getting water out of that cloth. Not this way, not any other way. So the heart has to squeeze the blood out And it does this by this twisting motion. And the beauty of this twisting motion is exactly like how we do when we ring the clock. We do one hand one direction, the other hand the other direction. It is the same way in the heart. At the basal level, it is in a clockwise direction, versus at the apical level, it is in the anti-clockwise direction. And this is again as a result of these two helices which are placed, bands of myocardial bands which are placed orthogonal to each other. So you have this twisting motion of the heart which squeezes the blood out, and this is called the rotational motion of the heart or the circumferential motion of the heart. Now, we are all used to using tissue Doppler, and we are all used to using Doppler to measure velocities, especially PW. What tissue Doppler imaging does is, instead of putting it at any place over a valve or an orifice or to measure the speed at which the blood flows, we are placing that probe over a portion of the myocardium and see how the myocardium moves in the cardiac cycle. And all of you, I'm sure, know E dash and A dash. Do all of you, how many of you use E and A dash during echocardiography? Great. We have a fantastic audience, which makes my talk a lot tougher. I'm afraid of the questions then. So exactly what you do, the E prime and A prime is measuring the annular velocity, and that is this first form of tissue Doppler that came about. Now, they took that one step further. They said, well, how do I conveniently do this for the rest of the myocardium? And then you came about what you call parametric imaging. That is, you have the whole tissue Doppler, which is superimposed on your 2D, and it is colored. Just like how you have Doppler red towards the probe and blue away from the probe, same way in tissue Doppler imaging, you have all that movement of your myocardium, which is towards the probe, is in red, and which is termed as a positive velocity, and away from the probe it will be in blue, which is the negative velocity. So once we have this parametric imaging, software makes it easy for us to make measurements at a later stage. Now, if we were able to place probes here, a point or region of interest or ROI, at different parts of the myocardium, you will have different velocities, like you know your E prime, A prime, and S. So this is the myocardial velocity that we measure in meters per second. If we also know the distance between each of these regions of interest, so each of these points we know are a fixed distance, and that the computer does automatically. Because we are able to get these velocities and we know the distance between each of these points, we can then calculate the strain rate. Okay. And if we integrate this curve against time, also we know, because we know it is being captured over so many milliseconds, we will get a strain curve. So you can see all three curves. This is the one that is most familiar to us. We have an E by E dash, which is nothing but the velocity, myocardial velocity that you have. Added to that distance you add, you will get a strain rate curve. And what you can see is that strain and strain rate curve look like mirror images to each other. The first one, the S curve is positive over here, the S curve is negative, or the systolic curve, and the diastolic curves are negative versus when they are positive. The strain curve, however, it is a lot simpler and a lot easier for us to use. So the software which is there in the newer echo machines will be able to do these things automatically if you put a probe or if you put a region of interest in any part of the myocardium. As I told you, this talk is about this. And I need to refresh all of you about the cardiac cycle. All of you have studied it, and let me just give me a brief minute of time for us to go through the cardiac cycle once again, because it is very important and it forms a correlation for us for our future discussions about strain and strain rate. So let me start with the advent of systole. Now, you know the QRS, and there is the start of the QRS to the start of systole, there is about 30 to 40 milliseconds. Okay. And this is the time where the electrical impulse propagates, you have calcium that is released actin myosin combine together and systole starts. And as systole starts and the mitral valve closes, you have the first period, and the aortic valve is still closed, and you have the period of isovolumic contraction. That is, the heart is continuing to contract, and it is doing so at a more forceful pace, but because the mitral valve and the aortic valve still remain closed, there is no flow of blood going out of the heart. And that is why it is called isovolumic contraction. As the pressure builds up within the left ventricle and it crosses the diastolic pressure in the aorta, okay, or what we call the afterload, the aortic valve opens. And once the aortic valve opens, you have the start of your ejection period. So this is the second phase of our cardiac cycle of ejection. And the ejection period, within the first half, it reaches the maximum ejection. So the heart contraction actually stops somewhere around there, around the peak. After which it is because of the inertia and momentum that is generated by the heart's contraction, the blood is flowing outside into the aorta. And as the pressure slowly drops below the below our aortic diastolic pressure, your aortic valve closes because there's a reflux of blood, and that causes the closure of the aortic valve. The closure of the aortic valve is the point where the ejection period ends. And now you have a closed aortic valve and a closed mitral valve. Again, you see the pressure dropping, and there is no inflow of blood within the heart, so the size of the heart remains the same. At the point where the LVEDP, or the left ventricular pressure, drops below the left atrial pressure, the mitral valve opens, and then you have the start of the diastole. Now, diastole itself is hugely complicated, but just to simplify it, you have the early phase of diastole, where there's a large initial rush of blood due to this negative pressure between the heart and the pressure gradient between the heart and the atrium is, followed by a period of diastasis. Because of the equalization of pressure between the atrium and the ventricle, there is no further flow of blood into the ventricle. And you have atrial systole, which marks the end of our cardiac cycle. Right. If there are any questions or doubts any of you would have, please be free to stop me at any time. Here's an interesting and important phenomenon. Again, is because of the double helix. And I've marked 1, 2, 3, 4, 5 as the different phases of the cardiac cycle here on an M mode, which has tissue Doppler in it. Okay. Here you see at the isovolumic contraction phase, this is the endocardium and this is the epicardium. Okay. And as the endocardium starts to contract, okay, part of the epicardium is actually starting to relax. So let's keep this in mind, and this is important for us to correlate with what we are going to see on our strain and strain rate curve. So this is one peculiarity which repeats again in isovolumic relaxation period. So you can see here in red is that the endocardium is actually relaxing, and it's in red, is going towards our probe, which is placed here. So red is anything that's towards the probe or relaxing. At the same time, the corresponding epicardium is actually contracting. Okay. So this is again, as I told you, as a result of the double helix, and displays, just keep this in mind because we're going to come back to this as we're going to see our strain and strain rate curves. Here is again a simplified picture of the phases of the cardiac cycle. And here is a pressure volume curve. I think I will skip this due to, and go on to my next slide. Point number 5 is when we describe contraction in apical four-chamber view, and I asked a lot of my colleagues, how does the heart contract? And they show me this way. And this is our inherent bias that we have, that the apex goes towards the base and then relaxes. However, The truth of the matter is that the apex is fixed, and it is the base that goes up and down, causing the ejection. So this is another important aspect that you can see that yourself in this picture. Here is diastole, okay, and here is your mitral annulus. At systole, the mitral annulus has actually moved towards the apex, and it is not the apex that is moved towards the base. So the apex is constant, and it is the base that is moving up and down, which is causing the ejection. Okay. So what is the consequence of this? Because our probe is there at the apex, and any velocity towards the apex is considered positive. So contraction would have a positive myocardial velocity because it's going towards the apex. And relaxation would have a negative velocity because it's going away from the apex. So this is point number 5 that I would like you to remember, is that the contraction happens base to apex and back. The apex is entirely fixed. It is the base that moves up and down. So I need 10 minutes of your attention. That is all. And it is like these news channels. If they want to grab your attention, they're going to say, this clip is not suitable for children. And we all will pay more attention to this. So the next 10 minutes, I'm going to describe the systolic velocities that you are going to see. And I hope to be able to describe the systolic velocities to you at different phases of the cardiac cycle, so that you will A, understand how the heart is working, or myocardial mechanics, and B, apply that to strain and strain rate imaging. Okay. So the following is not suitable for viewing of children. So I've said that. Okay. Now, this is what we are used to. Okay. And this is what I want you to get used to now. Okay. And this is the output we get from parametric imaging. And it is our job to be able to decipher all these different curves over here, okay, and make sense of them. Okay. You may not need to use these in the future at all, because things are becoming more automated, but it is important to know. And knowing what you are seeing and knowing what you're doing is, as Baba said, is one of the most important things to do. Not doing things without knowing is the most dangerous. So my aim in the next 10 minutes is to explain this curve to you, so that you will be able to understand what these curves mean. And my request to all of you is to stop me and ask any clarifications, because that is very, very important. Okay. So here is a sample of what we need to mark over here. We need to mark the different phases of the cardiac cycle on this velocity curve. As you can see, it is a velocity. You have positive systolic and a negative diastolic. This is just like your E prime and A prime that you see in your everyday life, but this is a little more smoothened and simplified. So our aim in the next 10 minutes is to identify the different parts of the cardiac cycle from this curve. That is all that we need to do. We need to mark all these lines which are here down here. And if we are able to do that, we are king. So let's start off with the first part of the cardiac cycle, or the isovolumic contraction. Now, I will tell you why the term isovolumic contraction is not an appropriate word when we deal with myocardial mechanics, and we'll do that later. So my first event in my cardiac cycle is the closure of the mitral valve. And that starts over here is the mitral valve closure, and that marks the start of my cardiac cycle, or marks the start of systole. So initially what people thought after looking at this curve was that, hey, you have one positive deflection over here in velocity. So that has to be the mitral valve closure, and that has to be where the systole starts. Let's see. Now, to mark or to find out where the mitral valve is opening and closing, where the aortic valve is opening and closing, we use timings. That is, simplest thing you can do is place your ECG Okay, and that is actually the first thing you need to do when you do strain and strain rate. You need to get a good ECG. Okay, and this ECG has to be clear. You should be able to identify where the start of the QRS is. Okay, the start of the QRS is the start of the electrical cardiac cycle. We are interested to know where the mechanical events are taking place within the cardiac. So we can put this together along with a Doppler, which is very good. Doppler will tell us exactly where the aortic valve is opened. That is the time interval from the start of the QRS to here is where the aortic valve is opened, which is good. The same you can do with mitral valve. You can mark along with the ECG the start of the mitral valve opening and the closure of the mitral valve, which is something you can do very easily. Here you have the start of the aortic valve opening, and of course here you have the aortic valve closure. However, this is an approximation, and this is something that you and I can do. But please understand, we are as though transferring timing from one part of the cardiac cycle of some other cycles to our strain rate. Okay, I want you people, of course this is something that we do on a day-to-day basis, but how to identify the opening of the closure of the mitral valve and the opening of the aortic valve on this curve without using those timings. So if you know that, you can always go back and use the timings for the sake of convenience. So there are two ways to do timing. One is to superimpose the ECG with your Doppler and mark on your Doppler aortic opening and closing and mitral opening and closing. That is how all of us do it on day-to-day practice. I, for instance, want to tell you in this graph which represents which, so that you have a clearer understanding of the events that are taking place. So the first thing you need to do is identify where is your zero. Okay. Your baseline is very important, where the negative contraction or the negative velocities cross over to the positive. So if you have this reference in mind, it makes easy for you to interpret all these different squiggles that you will find on the screen. You know your S wave. Your S wave is very prominent. That is the most prominent positive deflection in our velocity curve. Please note that everything I'm talking to you right now is about your myocardial velocity curve only. Once we get a myocardial velocity curve right, that can very easily be interpreted into strain and strain rate, and the machine does that automatically. We don't need to worry about it. So in this velocity curve, you know the S, which is the maximal systolic velocity. The point of origin of this curve, where it takes off, is the point of the aortic valve opening. So at this point, the aortic valve opens, and because the aortic valve opens, the systole starts, and there is a huge amount of movement of the base towards the apex. So the heart is contracting very rapidly from here, and you will know that this is where your aortic valve opens. Okay. So we know where the aortic valve opens. Now we need to know where the mitral valve closes. Okay. Now, if this is the aortic valve opening, what is this curve which you see here? Okay. This isovolumic spike, as we call it, a lot of people wondered what it was, and they thought, well, the spike must be the mitral valve closure is causing this spike velocity. It is, but with a caveat. The mitral valve closure happens at the peak of the spike and not at the base of the spike. Okay. And how do we know this? Well, we know this because of a beautiful study that was published earlier this year with tissue velocities at frame rates at 1200 per second. Okay, this is unheard of frame rates. This is just a research lab. We can do about, say, 140, 150 frames per second. But if you go up, it's like taking the myocardium with a high-speed camera and analyzing the events that happened here. So in this high-speed camera of the same velocity curve, and you superimpose the point where the mitral valve closes and opens, you will find that this peak of this spike, or the isovolumic contraction, IVC spike, is where the mitral valve closes. So we know where the aortic valve closes, and we know the peak of that spike is where the mitral valve closes. So we now know the the first part of our cardiac cycle, which is the isovolumic contraction time. Right. Now, we have done with the pre-ejection period, so to speak. Now, we know the most prominent peak, which is the S wave. The S wave is the most prominent peak. You can always measure the amplitude and the time it takes from the onset of contraction to the S wave. Now, timing in all strain and strain rate or any tissue Doppler imaging does not happen from aortic or mitral valve events, but it happens from the onset of the QRS. So any timing that we do is done from the onset of QRS so that there is uniformity there. As you can see, just like in our pressure tracing, you have a very sharp initial uptake of the curve, which corresponds to the forceful ejection of blood, and which slowly tapers down and it crosses the negative. So the next question that people were asked is, where is the aortic valve closing? And well, everybody thought the aortic valve closes there. That is a point where the curve slowly goes into negative. However, that wasn't true. Okay. And the confusion was, what are these two spikes? You have a negative spike here and a positive spike. How can that be? What is this negative and positive spike? Was a question that was there. So the end of systole, there was a negative spike, and what was the reason for this negative spike? And the reason goes back to that epicardial endocardial image that I showed you, that at one point the epicardial is pushing the other way and the endocardium is pushing exactly the opposite way. And we can see this in our Dopplers, our M modes that we do. So if we do a careful M mode, you see what you call a systolic notch. You see that there and the other one there. So this is the point where the aortic valve closes. And it is this systolic notch that will tell us the point where the aortic valve closes. So back to our figure over here, this negative spike is because of that systolic notch, is because of the fact that there is a negative pull of the epicardium that is taking place at that end of that aortic valve closure. So we have aortic valve opening, which is the start of that limb. The limb extends down, and you have a negative part. You have relaxation part taking place within the systole. And this was, hey, how can you have relaxation taking place during systole? The relaxation is because of that epicardium, which is actually elongating, actually relaxing at the end of systole. And the end of that negative spike is where the aortic valve closes. So we have reached milestone number 3. We have pointed out where the aortic valve closes. And in tissue Doppler imaging or strain and strain rate imaging, this is the most important point. And this is the first point that we should actually look for, because this is the India-Pakistan border. This is the place where systole transitions to diastole. So the first thing I do after establishing my baseline is to find this point of aortic valve closure. Thereafterwards, do everything else. Okay. But proceeding forward, I have identified the point of aortic valve closure there, and I want to know when the mitral valve opens. Okay. I need to pinpoint the second last marker for me. So as soon as the systolic aortic valve closes, there is something called the aortic valve bounce, and this is because the myocardium suddenly comes to a stop and it reverberates a little bit. Okay. So this is part of the isovolumic phase in which the small positive velocity you will see in the isovolumic phase. So this AVC bounce is part not of the diastole but is of the aortic valve, is due to the fact that the aortic valve has closed at that point. Now, here you can see an actual picture of the velocity. First, whenever you see this graph here, you have to ask yourself, is it velocity, is it strain rate? Now we know it's not strain because strain is one simple uniform negative graph. It is systolic positive and 2 negative, so it has to be velocity. Strain rate is the opposite of that. So here you can see, you see that positive part where the mitral valve closed. you see this point where the systolic wave goes up, and this is the place where the aortic valve opens. You see contraction taking place over here, and there is a negative wave which is the end of systole, and it is here that the aortic valve closes. You see the positive wave which is there afterwards due to the aortic valve bounce. Okay. So where does the mitral valve open? And that is the question. And the opening and closure of the mitral valve are some of the most complex and most debated topics of cardiac mechanics. And everybody has 10 different reasons why the mitral valve closes and opens. Now, how do we find out where the mitral valve opens? And we can do that very easily visually. Okay. Because we are doing it in the apical views, we can see the valve opening and closing. Okay. But we need to know pinpoint exactly. And if we place this region of interest over the tip of, or just as the tip of the leaflet of that mitral valve, this is in red, and you can follow this red line over here. I'm not sure if you can make out. At this point over here, this red line zooms up. Okay, and that is the point where the mitral valve opens, because there is a sudden, mitral valve opening is a very sudden phenomenon. So as soon as it opens, it moves apically, and that causes a positive velocity. So while we are doing our strain and strain rate, if you just put one of those markers at the tip of the mitral valve, you will find a sudden positive spike, and the place at that sudden positive spike is where the mitral valve opens. And this actually also corresponds to the place where that aortic valve bounce becomes negative. So we have now completed marking the 4 most important physiological phenomenon that will demarcate our different components of systole, diastole, isovolumic contraction, and relaxation. Here is another example. First, baseline, as I said, and once baseline we put, the next thing I do is, here you see the aortic valve closure. After the negative, I identify my S wave, and the first thing I do is mark my aortic valve closure, which is the end of the positive wave. Then I mark my aortic valve opening, which is the beginning of that deflection, the positive deflection of my systolic wave. I have my spike over here, and I know at the peak of my spike is my mitral valve closure. And I also mark my mitral valve opening at that location. So this is how you could mark it manually. You don't need to do this, but you need to know how to do it, because you need explanations. What is that positive? What is that negative? What is that? If you don't know what you're seeing, you will tend to become more and more confused. The machine will mark this for you automatically, and then you can also interpret it a lot better. Of course, here, as you know, is where the same mitral valve closes. So the machine will give you these 3 curves. And this is the end of my 10 minutes, by the way. Is there any doubt, or anybody have any questions about this tissue velocity curve? Now is a good time to ask. No. The baseline is there, 0. You have to visually see where it is so that you keep in mind. I just want you to know where that 0 line. Sometimes it's very confusing. It's not marked separately with red. You don't need to mark it, but you need to know visually where it is. Okay, so once you have the tissue velocities, or you measure it, the machine will automatically measure the strain, and it will automatically measure the strain rate. Now you see, there are so many spikes in the tissue velocity, there are so many spikes in the strain and strain rate. In the strain curve is a very smooth, simple curve. Okay. And this is what we are going to use clinically more and more in the future. Okay. Because this curve will tell us that, hey, the myocardium has deformed 20%. 18%, 15 to 18% is the normal deformation. It is shortened by 20%, and you know that is normal. So just like how you have ejection fraction is say 55%, it won't be long in the future where somebody says, this guy has a deformation of only minus 10%, so I think he's higher risk or something of that sort. So it is important for you to know this. The strain and strain rate and velocity curves are like mirror images. Okay, you have S, E dash, and A dash, and same way you have an S strain rate, E strain rate, and A strain rate. Okay. So this systolic is positive and the diastolic events are negative, versus a mirror image. The systolic is negative and the diastolic curves are positive. Okay. So you should be able to identify whether it is tissue velocity, strain, or strain rate or strain by looking at these curves, and then you will be able to understand what you are seeing better. Diastolic events, I'm not going to spend another hour about this, so I'll quickly go through this. The nice thing about E by E dash is that all of us have come to know and understand diastolic events a lot better. And I think Srikanth here will be able to explain these things far better than I will. So I will quickly run through the diastolic E and A, which you will see. And what are the three components that affect diastolic function in the heart? First is restoration forces. Okay. The heart is compressed, and in diastole it has to expand. And it is that expansion that provides the negative pressure for the initial blood to come in. And it's very similar like the spring that we have all played in. Okay. As it contracts, it has kinetic energy inside it, which recoils, restoring the shape and the geometry of the left ventricle. And any alteration in this, of course, will affect our diastolic events. So, other than the ventricular restoration forces, you have the left ventricular end diastolic pressure. I won't go too much in detail. And of course, you have the rate of deceleration, which is expressed as tau. So, it is three important components that affect diastolic function. And I will just skip through this. You all know the different, you have tissue Doppler, which is now, you have mitral velocities that all of us use, you have pulmonary vein, atrial sizes, there are so many different ways and methods where you will use to measure diastolic function. Just the golden marker is invasive measurement of your mitral transmitral gradient. And it was quickly shown that the mitral velocities very closely correlate with the mitral valve gradient. Then you had the deceleration time, which tells us how much time it takes for that E to come down. Shorter, we know, is far worse. All of us use this in our day-to-day practice. We measure our EA by mitral flow, and we add the tissue Doppler over here. Please note that the only point I would like to tell you is that pseudonormalization and restrictive forces, you will always find an abnormal mitral annular Doppler. Always. So except the normal one where E is bigger than A, in every other physiology, your tissue Doppler is always negative. So a combination of both will always give you the right answer. We also know that E by E dash more than 15 corresponds best with high LVEDP and wedge pressure by wonderful studies that were done. This is the earliest study of pulmonary vein, though I personally have not used it for a very long time. So this was a 1993 publication in dogs as to the pulmonary vein velocities correlation with the LVEDP. Now, I'm going to very quickly go through what are we going to measure and how are we going to measure it. Okay. So these are the strain rate curves here on our right, and this is our strain curve on the left. Okay. Now, strain is a very simple uniform curve that you see. It's not uniform, but it is at least very simple visually to look at. And you have a systolic strain. So when you mark the aortic valve closure, the strain that corresponds around that time is the systolic strain. And sometimes you may have a deformation or shortening after the end of systole, and that can be marked as your maximal strain. You have systolic strain rate IVR strain rate, E strain rate, and late strain rate. So these are different measures you can make on the strain and strain rate curves. We maximally use in clinical practice the strain curve. We use the strain curve because it's easy. Once we know where the aortic valve closes, we know whether it is systolic strain or if the strain is post-systolic, and which is the maximal strain. Okay. Here are some of the intervals. This is peak time to the systolic velocity that you can measure from the start of the QRS to the start of the S wave. You have time to relaxation you can measure. You have the time to peak systolic strain and the peak systolic strain rate, whole bunch of them on and on. Okay. Now look at this figure. This is the strain rate which is there, and the strain, this is the strain figure which is there, predominantly negative, a nice simple graph to look at. So this is what you and I are going to be using in the future. The nice thing about the strain is you have aortic valve closure and you have the peak systolic strain over here. You at times may have a deflection which is after the systole. So there's a few segments continue to contract after the closure of the aortic valve, and this is called post-systolic shortening. Okay, this post-systolic shortening is seen in 30% of the myocardial segments, and it is seen in abnormal cases. My colleague will tell us more about it. So when we are making measurements about strain, we have peak systolic strain and a peak strain which might be even after the aortic valve closes. So this is a big list of all the measurements, and we don't need to know all of them. Once we know strain, we can calculate strain in all the myocardial segments and make a bullseye. And my colleague will tell you more about the bullseye part of strain. And this is what you're going to see in the future. You're going to calculate strain for all the 17 myocardial segments, and you will depict it like this. And you will tell a person, hey, this is the average strain in all his segments is 20, so you know it's entirely normal. Or the average strain is 5 or 4 or 3 or 2 or 10, which you know is abnormal. I will quickly skip through the rest of these graphs and come to a few aspects when you are measuring strain and strain rate. Okay, you also have to know that there is a clear difference between the base, midwall, and apex. Obviously, the apex is not moving, so the velocities that you will get at the apex will be smaller versus the base. Base is the one that is doing all the work, and your velocities that you will get and which you will get in base and mid and apex are different. And you can see that very clearly that if you have the red curve, which is the apex, and this yellow curve, which is the base, you can see the maximum movement is done by the base and not the apex. At times you will find that this curve this is your strain curve that you can see. It is a nice negative curve, but another segment is entirely opposite to that. So this segment is actually moving away, or it is dyskinetic, and this is how you're going to make out. Here is an example of a strain curve, and you have a marker of your aortic valve closure. I told you this is our India-Pakistan line. Aortic valve closure is very important because it tells us where the systole ends and the diastole starts. If there is strain after the aortic valve closure, what does that mean? That means that there is some segment of the heart which is contracting at the time where everything else is relaxing. Okay. And here you can see this is a normal strain, and you have a little bit of post-systolic shortening, which is okay, which is normal, because this strain curve is normal. This is seen in 30% of our myocardial segments. However, this curve is abnormal. Okay. You can see that this is a normal strain curve versus this strain curve, which is after the systole, is abnormal, and the amplitude is also abnormal. So if you find a normal amplitude strain with post-systolic shortening, we are fine, we are good. If you find the amplitude is small and there is significant post-systolic shortening, that is abnormal. And this is something that and why does this occur? It occurs due to the fact that the ischemic segments, don't contract and relax well because they have an inherent ATP problem. Okay, so while they are relaxing, okay, they aren't relaxing fast enough compared to the other segments, and this causes a pull on the surrounding segments as well. And this has been very well validated. And here is another useful use of our tissue Doppler imaging, and this is what I commonly use it for, is that we can, your S velocities, that is our systolic velocities, are different in different segments. That means two segments are not contracting together, so there is some amount of dyssynchrony. So in the same patient, after he had left bundle branch block, and this is the septum and the lateral, and you see there's significant septolateral delay, and after a pacemaker you see it came down to 230 milliseconds. So what are the pitfalls that you should watch out for? And this is Srikanth, I have another 2 minutes. Is reverberation. All of us have seen ribs and have problems with ribs while doing echoes. Ribs create a big problem for tissue Doppler imaging. You must know where ribs are. That causes those artifacts, and that causes a whole lot of problems in your velocity graph. If your marker that you are placing goes into the blood pool, you will have a lot of noise. Okay. So when you are doing strain and strain rate imaging, it is important for us to know where that marker is at all times, so that you will get a clean graph and not something with a lot of these noise. Translation is the motion of the heart as it contracts and as we breathe. Each time we breathe, the heart is moving, and sometimes this marker that you place may actually go away from the region of interest because of the motion or because of respiration. So if that happens, again you'll get a very confusing graph, and the simplest way to do it if you have this problem is capture this at end of expiration, where you may have a better chance of that. And finally, angle. Now, tissue Doppler has, as all of us know, is angle dependent. If it is straight, it's great. If it is there at the corners, it is entirely different. The computers compensate a lot for it. So it's measuring base, mid, fantastic tissue Doppler. But if it comes to the apical segments, there is a problem. There is a problem because our beam is straight versus the apical segments are contracting differently. So instead of actually measuring strain, you will be measuring radial strain. Instead of longitudinal strain, you will actually be measuring radial strain. So that is something you should keep in mind while doing strain and strain rate at that. So to overcome all of this, and this is a modality that you and I will be using in the future, you have speckle tracking or strain. There is no Doppler involved in it. Okay. There is a good 2D image, and what they do is these white speckles, as they are called, the computer marks these speckles and sees where the speckle has moved from one frame to another. And hence, it knows the displacement or how much the speckle has moved, and it can calculate strain directly without any Doppler, without time, velocity, nothing. So the future of tissue Doppler, imaging will be tissue Doppler, speckle-based imaging, and you will get an automatic strain and strain curve like this, like some of the machines that we will show you here. Finally, radial strain can only be measured in the short axis view for obvious reasons. You need to know when the wall is contracting and relaxing, and this can be done via speckle tracking or 2D strain a lot better. One or two final slides about rotation. As I told you, rotation is the most powerful force that there is of cardiac contractility. However, the tools we have to measure this rotation are still in the research, are still in things like the Q lab that you have, and less on machines that we're going to use, but that is going to change in the future. So the rotation can be, one is clockwise, one is anti-clockwise, and the difference of this is called the torsion. And that tells us how the LV is contracting in a radial fashion. Thank you for